Good evening, all. And today we are here. Now we are heading towards the third session of the lecture of occupational therapy skill building webinar series that has been organized by Academic Council of Occupational Therapy. As you know, it's a very special day today, as we have with us our extremely learned, a proficient person who is an international faculty, and the topic to be covered today is again a unique one, that is complex reticular system of hand and its influence on digital motion, hand specialization and rehabilitation. This is an area of my interest also. Now I remember Chinchalkar said long time back, almost now 18 years, when I had attended your first lecture series at Nagpur. So that was great. You might remember that I came there and we both, Meenakshi and myself, joined there. And still we have the memories and the learning of that lecture. Now, moving ahead, I would like to first invite our Honorable President AIOTA, Dr. Pankaj Bajpayee sir, to give a welcome address to all. Bajpayee sir, please.
Thank you, Dr. Batra. This is my first interaction, though online, with Dr. Shrikant J. Chinchalkar, sir. Good evening, sir. We are really obliged to have you here. I have heard your name. Are you getting my voice, Dr. Batra?
Yes, we can hear you very well.
Okay. Thank you, sir. So I have heard your name many times before. I could not attend any program though, but definitely I heard your name. I think 3 or 4 programs you have conducted in Nagpur. So when the Dr. Batra told me that I want to invite Dr. Chinchalkar for this topic on related to, and because by some way or from the some sources I got to know that you have a special interest on hand, and you have conducted those sessions for hands only. So that is why I thought you are the best person in international faculty also. So I welcome you, sir. It is a great opportunity for every participant to hear you and get the information and to develop their interest and their knowledge also. So thank you very much, and I welcome the attendees also in this program, all the OTs who have registered and who are there on board for this program. They will definitely get some upgradation in their knowledge related to hand. Topic is very interesting, complex retinacular system in hand and its influence on digital motions. Nowadays, occupational therapists are working more on the pediatric area, but I know that occupational therapists have inherently have interest in hand. So whenever they work with the pediatric population or any other population or a traumatic type of cases, they always see towards the function of the hand because of their inherent interest and their functioning area. So I welcome all the participants. I welcome Dr. Chinchalkar sir. I also welcome our Dean Ecott, who is who will be there to moderate the program as I came to you. And Dr. Batra, thank you for coordinating this program very well. There is a team behind this program who is conducting all the providing technical support. Dr. Joseph, our secretary of All India Occupational Therapy Association, I welcome him also. So, Dr. Batra, you can start with without any further.
Yes, sir.
Thank you.
Thank you, sir. Sir, now without wasting time, I would like to start introducing our speaker first for today's webinar. As you all know that Chinchalkar sir is a quite renowned personality. He is Masters in Occupational Therapy, and he is also a postgraduate certification done from IPMED. Sir is OTR and is a certified hand therapist. He has almost more than 50 years of experience in hand rehabilitation And he's also an active member of Canadian Association of Occupational Therapy, also a charter member of American Society of Hand Therapists, and lifetime member of Canadian Society of Hand Therapists. Chinchalkar sir is also very renowned professional. He has many publications, many research papers on his name. So sir has also chaired many sessions. He has published almost 30 research papers into various index journals. He has also developed various patents on his name and assistive orthology confirmation to develop elbow CPM. He has also received a US and Canadian patent on his printing device assistant for intra-articular digital fracture. Sir is also assisted Toronto Medical Corporation for developing wrist CPM. And apart from this, he has been the resource person for many conferences, seminars, and others. And Sir has also chaired many scientific sessions. Apart from that, he has reviewed been the reviewer for the Journal for the Hand Therapy, Journal for Microsurgery, and other. And he has formed also Indian Society of Hand Therapists, and currently is acting as the executive committee of member of ISST. Sir has also served many department, hospitals, committees for the program, quality assurance, control, and accreditation procedure. And he has been the member of scientific committee on many occasions. So, now I would like, without wasting, I would like to request Chinchalkar sir to start with his talk, deliver his lecture. Sir, Chinchalkar sir, please.
Thank you, Dr. Batra, and thank you, Dr. Bajpayee, for introducing me. I'm really honored to be invited for this particular session, and I'm delighted that I'm again part of Indian Society or Indian Occupational Therapy and Indian Hand Therapy Society. So let me share my slides, just 1 second. So today we are going to talk about the complex retinacular system of the hand and how does it influence motion of the fingers and motion of the thumb. So if you look at the definition of retinacular system, we can very well say that the system is basically formed by a network of thickened connective tissue bands. And these bands especially surround and secure the tendons and allow stabilization of these structures when the muscles contract, so that it facilitates, restricts, and guides specific motion that is essential for hand function. So the hand is quite complex anatomical structures, mechanical structures. Basically, lot of motion that we perform from flexion to extension, extension to flexion is dependent on functioning of the retinacular system.
He was not conscious only.
I see somebody is talking in the back, so as a result, it's causing quite a bit of disturbance. So I would request you to please mute your microphone so that there is no disturbance to other attendees.
And she is also just semi-here. So she's trying to do her level best to just be there, but you know how it is.
I'm wondering who's talking in the back.
Yes,
so
hello,
please
somebody,
mute.
I think, anyone, please, please keep yourself in mute mode, please.
I will.
Please,
I will.
request everyone to keep yourself in mute. Thank you.
Okay, so looking at the definition of the retinacular system, therefore, that the retinacular system is a network of thickened fascia. Basically, that is it surrounds the tendons.
Come straight to yours.
Hello, hello, everyone, please keep yourself in mute. Request.
Okay, so let me repeat it again. The retinacular system is a network of thickened fascia or connective tissues that secures the tendons. It helps in stabilizing them when the muscles contract and even otherwise, so that it facilitates, restricts, or guide specific amount of motion that is essential for variety of hand function. After all, what are the retinacular system in the hand? So these are specific ligaments, which again influences the motion of the tendons when we move our fingers from fully flexed position to fully extended position. But as the hand is moving from flexion to extension, it's essential for the tendons to be stabilized in a specific degree of position so that there is an optimum precise motion that occurs at the metacarpophalangeal joint, interphalangeal joint, which is proximal interphalangeal joint and distal interphalangeal joint. But in addition to this, as we perform motion of the fingers for specific action, we must have distribution of appropriate forces that must be transmitted on the fingertips so that we can pick up the lightest object between our fingers without causing a crushing action of these structures. So here, if you look at these slides, the pictures on the left-hand side, you can see that one person is making a woodwork using a specific tool. He has to exert exact amount of pressure on these fingers specifically for him to carve a specific object. And on the right-hand side, this is a person who is forming a particular pot, doing a pottery. You can imagine that if the precision of the right hand and left hand is never ever be able to create such a masterpiece. So I personally call these retinacular system as tendon supporting ligaments. And looking at these tendon supporting ligaments, we can see that right from the wrist onwards, on the dorsal side of the hand, you have an extensor retinaculum. As we travel along the extensor tendons, right over the palm, on the dorsal side, we have a structure that is called as the juncture tendinum. And as we walk along the tendons and reach the metacarpophalangeal joint, we see we have sagittal bands. And as we travel towards the fingertip, between the proximal phalanx, middle phalanx, and distal phalanx, we have a structure that is obliquely oriented, going from the proximal phalanx onwards, going to the distal phalanx. And that, because it's spiral in its appearance, it is labeled or called as the spiral oblique retinacular ligament. And then at the PIP and DIP joint, we have another structure that creates a mechanical balancing act. At the PIP joint, we have a transverse retinacular ligament, and of course, distally, we have a triangular ligament. So you can very well see that all these structures, right from the extensor retinaculum to the fingertip, that is triangular ligament, all these structures must work hand in hand, allowing the tendons to move either dorsal or volar to the anatomical axis of rotation, or distal or proximal to the anatomical location at PIP, DIP, and metacarpophalangeal joint. So look at basic function of each and every structure, and so that we can really understand how these structures influence motion of the tendons and how these structures actually cause motion of a particular joint. So if you look at the cadaver on the right-hand side, you can see that this is a broad ligamentous structure covering the wrist joint. We call that as the ligamentous band, which stabilizes the extensor tendon during wrist and digital motion. So on the right-hand side, if I play this video again, you can see that this person had a surgical procedure who had tenosynovectomy, and the surgeon who was performing tenosynovectomy did not really understand the functioning of the extensor retinaculum. So he did a radical excision of the extensor retinaculum, and therefore the tendons, as you can see, are bowstringing at the level of the wrist, and subsequently the power is dropping at the metacarpophalangeal joint, producing what we call as an extensor lag. So the disturbance of extensor retinaculum is creating an imbalance at the wrist level and subsequently creating mechanical issues at the metacarpophalangeal joint. And over time, if it is not reconstructed or taken care of surgically, then patients will end up having secondary swan neck deformity at the PIP joint. So if you look at the mechanics or mechanical studies that have been done on extensor retinaculum in terms of identifying its biomechanical importance, we can very well see that upon division of extensor retinaculum, the extensors have a strong tendency to bowstring, as you can see right there. So this is the fourth extensor compartment of the extensor system. So actually, I performed quite a number of dissections, especially in our biomechanics lab, with the residents from orthopedic surgery and plastic surgery, so that they can understand the importance of various anatomical structures and follow along the specific guidelines in order to preserve motion of the tendons and in order to preserve functioning of the metacarpophalangeal as well as interphalangeal joint. So here, as you can see, that upon dividing the extensor retinaculum, the extensor tendons bowstring, and subsequently the strength of the extensor is lost at the metacarpophalangeal joint, causing an extensor lag. So if you look at the extensor retinaculum, truly it is formed by or made by the infratendinous and supratendinous layer. And between these two layers of the extensor retinaculum, there are vertical septi that keep these tendons in their precise anatomical location. So if you look at the extensor compartments, they are divided into 6 extensor compartments. The first being extensor pollicis brevis and abductor pollicis longus. So these are the 2 radial extensors which are primarily responsible for performing radial deviation, but at the same time allowing motion of the extensor pollicis brevis. By using EPB, we are producing extension of the carpometacarpophalangeal joint. If you look at the second extensor compartment, we have 2 tendons of the wrist, radial tendons of the wrist, and they are primarily designed or placed in a way so that they can perform extension of the wrist and radial deviation. The third compartment consists of extensor pollicis longus. Fourth one consists of extensor indicis proprius and extensor digitorum communis. The fifth one is extensor digiti quinti or minimi, and the sixth one is extensor carpi ulnaris. So you can see that at the level of the wrist, they are placed, or extensor tendons are placed between the infratendinous and supratendinous layers of the extensor retinaculum. So as we walk from the wrist onwards, somewhere in the middle of the palm, dorsally, we see a structure that is called as the juncture tendon. And as we walk towards the metacarpophalangeal joint, you have what is called as a sagittal band. We look at the functioning of these both and how important these 2 structures should function. So focusing on juncture tendon, we can see that they are connecting to each and every tendon of extensor digitorum, especially extensor digitorum profundus. So it's a linkage system between the tendons, as you can see right there. And the function of the juncture tendon, therefore, is to maintain and retain divergent angle of the extensor tendon. So what I mean is, emerge out of extensor retinaculum, the tendons, as they advance towards their insertion, they diverge at a specific angle at the level of the wrist, and then at the metacarpophalangeal joint, they start to converge towards their insertion site. So juncture tendon, therefore, is the linkage system between or connecting the extensor digitorum communis, not profundus, sorry, I made a mistake earlier, extensor digitorum communis. So this linkage system is for the extensor digitorum communis, and then of course they are primarily responsible for transmitting force of the tendons going from one side to the other, as you can see right there. So here I'm pulling on the long ring finger extensor digitorum communis tendon. You can see that these juncture tendon that you see are transmitting forces to the adjacent EDC tendons. And as we walk along the extensor tendons at the metacarpophalangeal joint, you have a structure that is called as the sagittal band. So truly speaking, they are primarily responsible for maintaining the extensor digitorum communis tendon right over the center of the metacarpophalangeal joint in the midline. And especially, they are responsible for moving distally as well as proximally, as you see on the cadaver dissection. So during extension, the sagittal band is brought proximally because they originate from extensor digitorum communis and attached to the volar plate. And when you flex your finger, the sagittal band moves away from the metacarpophalangeal joint, as you can see in this cadaver dissection. So, in other words, because of the presence of sagittal band, which is originating from extensor digitorum communis and attaching to the volar plate, they are, besides maintaining the tendon in the midline and allowing to and fro motion, the sagittal band is also responsible for extending the metacarpophalangeal joint in collaboration with extensor digitorum communis. But many a times, because of disease process or because of trauma, the sagittal band ruptures. So classically, how do we test whether the sagittal band is ruptured or not? You can see that on the left-hand video, the person has an ability to extend the finger or maintain the extension. However, they're unable to extend the finger on their own. So here, of course, the person is demonstrating that when you flex your fingers completely and attempt extension, you'll see that they have an inability to extend at the metacarpophalangeal joint. So the test, therefore, is passively extend the finger and ask the person to hold. And as the person holds the fingers in extension, is able to retain that posture or position for a certain length of time until they move the fingers in flexion. And upon motion of the fingers in flexion at the metacarpophalangeal joint and interphalangeal joint, the tendons now drift in an ulnar valley, and they remain there because of lack of the sagittal band on the radial side. So as a result, patients have an inability to extend the fingers completely. So what exactly then is a sagittal band attenuation test? So the test is passively extend the fingers. Ask the person to hold the fingers actively in extension. And then extension, therefore, is well maintained for length of time. But when you ask the person to flex the fingers and attempt extension, patients have an inability to extend the fingers again after they have performed finger flexion. So again, this is a classic test. And if anybody is interested in reading about this, this is published in my paper which is published in Journal of Hand and Microsurgery. So often we see patients have extensor loss at the metacarpophalangeal joint. This is a lady who has rheumatoid arthritis. I'll play this again. So when she flexes her fingers, the tendons move in an ulnar valley because the radial side of the sagittal band is weaker and have ruptured as a result of an inflammatory disorder. So here, of course, if you look at the mechanism of her extension, she is able to relocate her tendons back in normal orientation because she still has intact capacity of the intrinsic or intraosseous muscle. So gradually over time, if this patient's extensor digitorum communis is not centralized, the tendon will remain in an ulnar valley. Because of the physiological changes that will occur distally, patients will end up having the intraosseous tightness eventually. And if that results into an intraosseous tightness, then the tendons have difficulty getting relocated over the metacarpophalangeal joint. So now you can see that when you dissect out the sagittal band on the radial side and attempt extension of the finger, you can see that because the tendon is now displaced in an ulnar valley, the line of pull now has changed. So as a result, you can see that there is an incomplete extension of the metacarpophalangeal. And secondly, if this continues over time, then of course, because the tendon has slipped in an ulnar valley, it produces stress on the juncture tendon, eventually causing the index finger tendon to also fall in an ulnar valley. And sequentially, because the line of pull now has changed, every extensor determined communis tendon will slip in an ulnar valley, producing an extensor lag, and this extensor lag over time will form what is called as intraosseous tightness, and this intraosseous tightness will magnify the load at the PIP joint, causing PIP joint to hyperextend, and therefore this pathological situation will then cause the extensor loss at the metacarpophalangeal joint, then eventually leading to secondary swan neck deformity. So that is because of the rheumatoid arthritis. But this young lady, when she worked out in the gym, she used to punch the punching bag, simulating action of her fingers as if she's she's involved in punching the bag just for the sports reason, and then she kept on developing quite a bit of weakness of the sagittal band, and eventually a point came when she had difficulty flexing the fingers. As you can see, the tendons are falling in an ulnar valley, and then the extension of her fingers was becoming quite challenging. So because the tendons have now slipped in an ulnar on the person's muscular system, and she is now starting to have inflammatory disorder produced by the pseudo extensor determined communis tendonitis. So management truly is to create a balancing act between the juncture tendon and the sagittal band, and then of course, then once the relationship is restored, then of course the tendons are retained over the dorsum of the metacarpophalangeal joint. But before we do that, it is important for us to see whether the patients are good candidates for the conservative management. So here the person has the splint that is maintaining the metacarpophalangeal joint in somewhat hyperextension, the central two fingers. And of course, using this relative motion splinting, then you can assess the patient's ability to extend the finger and see whether there is any deviation of the tendon. So just by placing the fingers in somewhat extended position at the metacarpophalangeal joint and asking the person to move or flex the fingers from flexion to extension, we can see that the tendons tend to remain at the dorsum of the metacarpophalangeal joint. So it's better to start treating these patients conservatively, try to restore the location of the tendons by creating a balancing act. And then, of course, over time, if the patient has not developed any subluxation of the tendon, well and good. If it doesn't help the patient, then of course they become the surgical candidate. So this patient we treated conservatively. Patient was advised to wear the splint for a period of about 3 to 4 months. However, she continued wearing the splint for about 6 months, and then she had complete restoration of function. So this is another case. As you can see, that patient has performed tighter and tighter fist of the fingers. The tendon started slipping in an ulnar valley. And then, of course, the patient had bilateral representation because there was an absence of juncture tendinum in this individual. So of course, this patient ultimately ended up having surgical reconstruction. However, we see that patients who have had trauma to their sagittal bands, as if they're punching a wall or punching a punching bag, you have a serious rupture, as you can see right here. And then you can see that upon having a band, the tendon is starting to slip in an ulnar valley. And of course, that causes quite a bit of abnormality at the metacarpophalangeal joint. You can see that as the person is performing motion of his finger, the finger motion is not smooth and synergistic. And because the patient is losing synergistic motion at the metacarpophalangeal joint, you can imagine the grinding force or frictional forces that are maximized as a result of the sagittal band trauma or attenuation. So the patient is again treated by means of the relative motion splinting so that there is lesser amount of deviation. However, in this situation, because the finger had a tendency to drift ulnarly, we had to place the finger somewhat in a radial direction to allow adaptive tightening of the sagittal band on the radial side. So for this situation, you can do the similar assessment and treatment for extensor digitum condris management, but especially if you look at extensor DT minimi is also likely to sublux as a result of an instability at the metacarpophalangeal joint. So looking at the finger as we walk along to the fingertip, between the proximal phalanx, middle phalanx, and distal phalanx, we have a structure that is obliquely oriented, and this is called as a spiral oblique retinacular ligament. So spiral oblique retinacular ligament, which is coming from the volar part of the proximal phalanx. This structure is volar to the anatomical axis of rotation at the PIP joint. It is dorsal to the anatomical axis of rotation at the distal interphalangeal joint. And because of its oblique orientation, we can say that, and as it is crossing over the PIP and DIP joint, we can call this as a ligament that is responsible for linking motion between the proximal and distal interphalangeal joints. So we often see that patients' fingers are immobilized in flexion for a certain length of time, depending on the anatomical injury or anatomical disturbance. A long-term retention of the PIP joint in flexed position obviously will cause an adaptive shortening of the spiral oblique retinacular ligament, and that will result into the positive retinacular test. So that means that what is positive retinacular test? That means that this oblique or spiral oblique retinacular ligament becoming tight does not allow extension of the PIP joint and flexion of the distal phalangeal level as you do this particular test. So retinacular test, therefore, is by extending the PIP joint towards neutral and attempting to flex the distal interphalangeal joint to see whether there is optimum length retention of the spiral oblique retinacular ligament. So we can see that because of the oblique orientation of the spiral oblique retinacular ligament, so here, of course, it is drawn somewhat differently. You can see that the oblique retinacular ligament, therefore, is crossing over the PIP joint. It is volar to the axis of rotation at the PIP joint, and it becomes dorsal to the axis of rotation at the distal interphalangeal level. And especially if you pay attention to the interosseous muscle and lumbrical muscles, we see that the lumbricals and interosseous muscles are volar to the axis of rotation at the metacarpophalangeal joint. These tendinous portion of the muscles, intrinsic muscles, then connect to the lateral bands. And as they connect to the lateral bands, they remain dorsal to the axis of rotation at the PIP joint and stay dorsal to the anatomical axis of rotation at the distal interphalangeal joint. So these two structures play a major role by influencing motion of the PIP and DIP joint. However, the majority of action done for retention of these structures in their proper anatomical location is as a result of normally functioning the retinacular system in the hand. So going further, you can see that these two structures definitely influences metacarpophalangeal joint motion and therefore action that occurs at the interphalangeal joint at the PIP as well as DIP joint. So keep in mind that the spiral oblique retinacular ligament is taut when finger is in full extension. The DIP joint flexion alone causes tensioning of the spiral oblique retinacular ligament, and of course, the spiral oblique retinacular ligament is slack when the PIP joint is flexed, and long-term positioning of the finger in flexion will result into the adaptive shortening or tightening of the spiral oblique retinacular ligament, limiting extension of the PIP joint and flexion of the distal interphalangeal level. And this is classically that we saw in the previous slide. So as we walk along the transverse retinacular system distally, we can see that the transverse retinacular system is connecting to the lateral bands of the extensor ditorum communis tendon. So this probe, as you can see, is passing through the transverse retinacular ligament. So this probe is passing through the transverse retinacular ligament, suggesting that the transverse retinacular ligament is responsible for preventing excessive dorsal migration of the lateral band. And if we look at the finger again in flex position, the long-term flexion of the PIP joint or long-term finger posture retention in a splint and flex position will cause an adaptive change, producing the tightness of the spiral oblique retinacular ligament. But at the same time, it is also going to contribute to the tightness or contractures of the transverse retinacular ligament. And because the transverse retinacular ligament is volarly oriented, it is responsible for counterbalancing the forces produced on the dorsal side at the triangular ligament. So triangular ligament is the structure as you see right there. These are the two lateral bands, and in the space between the two lateral bands are filled by means of a triangular ligament. So the function of the triangular ligament is to prevent excessive volar migration of the lateral band. So here in a specimen, we dissected out the triangular ligament, and we identified that when the triangular ligament is dissected out, the lateral bands fall volar to the anatomical axis of rotation at the PIP joint because they are influenced by the transverse retinacular ligament, and they do not allow relocation of the lateral band dorsal to the axis. So if the triangular ligaments becomes tight, you go on to developing secondary swan neck deformity. And if you have a disruption or attenuation or rupture of the triangular ligament, you end up having pseudo-Buchner or Buchner deformity of the finger. So therefore, the triangular ligament prevents excessive volar migration of the lateral bands, and therefore it is responsible for transverse retinacular ligament. So looking at this intricate relationship between the three structures, that is oblique retinacular ligament, transverse retinacular ligament, and triangular ligament, they are capable of balancing each other's forces. They are responsible for returning the lateral bands to its anatomical location following motion. These structures refine motion of the PIP and DIP joint for precision that is necessary for us to do very complex finger motion for specific activity. And they are responsible for optimizing tendinous forces continuously as we move our hand from flexion to extension and extension to flexion. So I dissected out few specimens to demonstrate that the relationship between the triangular ligament and transverse retinacular ligament is quite intricate. So when you flex your finger, I will play this again to stop this one. When you flex your finger, for example, as you see right there, the lateral bands must travel and, of course, translate volar to the axis of rotation, as you see right here. And during extension, the lateral bands should move dorsal to the axis of rotation at the PIP joint. And of course, this action of dorsal and volar translation of the lateral bands is influenced by normal functioning of the triangular ligament dorsally and transverse retinacular ligament on the volar side. So these are all the retinacular structures that are responsible for allowing the extensors to move distally, proximally, volarly, as well as dorsally. But whereas on the flexor side, we have a flexor retinaculum. So this is the specimen that we dissected out to show the carpal canal. It's a very narrow canal, as you can see, right distal to the pronator quadratus muscle. Right at the carpal region, if you look at the transcarpal view of the wrist joint, between the ridge of trapezium and hook of hamate, you have a ligamentous band that is connecting these two structures, which causes or makes the passage for the tendons to travel across. So these are the flexor tendons crossing over the flexor retinaculum, and right after the tendinous or flexor tendons emergence, at the flexor retinaculum, the tendon starts to diverge at a specific angle. And this is what is called as the flexor retinaculum, and therefore the flexor retinaculum is also responsible for allowing the divergence of the flexor tendons on the volar side. On the extensor side, you have extensor retinaculum that is responsible for divergence of the extensor tendon on the dorsal side. But besides flexor retinaculum at the level of the wrist, on the fingers we have what is called as the pulley system. So we have mechanical pulleys on the volar side. There are 5 cruciate pulleys and 3 annual pulleys, and their function is to allow motion of the joint in a very synergistic manner. So when we activate flexor tendons, flexor deltoideum profundus and superficialis, the motion begins at PIP, DIP, and finally at the metacarpophalangeal. So how do these pulleys function? They convert linear forces into a rotatory torque. They help reducing joint compressive forces and increase mechanical efficiency of the flexor so that the person can very smoothly move their fingers from fully extended position to fully flexed position. That's a very systematic process that the tendon motion goes through. So if you look at the literature suggested, based on some biomechanical analysis, that A2 and A4 pulleys must be preserved for full finger motion of flexion. So technically or academically, A2 and A4 pulleys are most essential pulleys in the hand. However, if we take the A3 pulley out, as you can see the A3 pulley and its orientation, when we take the A3 pulley out, then the finger has the flexor tendons have a tendency to bowstring at the A2 and A4 pulley. So therefore, some of the current research is suggesting that all the 3 pulleys must be preserved in order for the fingers to flex. So here, of course, on a diagrammatic basis, we removed A3 pulley, and we identified that as the person was performing flexion, or as the person would perform flexion of the fingers, because of the absence of A3 pulley, the tendon will start bowstringing. So let's look at this cadaver dissection to really appreciate how or what happens when you dissect out A3 pulley. So here, upon pulling on the flexor tendons, when the A3 pulley is deficient or not present, tendon bowstring between A2 and A4, and this type of situation will often lead or produce a PIP joint flexion contraction. So we looked at the functioning of the retinacular system on the dorsal side, on the volar side. So we can very well say, based on what we saw and based on what the anatomical and biomechanical studies have done, we can say that the retinacular system maintains the constant momentum of the tendons during flexion and extension. And as we move our fingers from extended position to flexed position, it helps in permitting adequate tendon motion proximally as well as distally. It helps in permitting precise tendinous motion and its migration volar and dorsal to the joint axis at PIP. And of course, it is responsible for transmitting exact force that is required for different types of activities our hands do. And because of all this, we have a tremendous ability to function using a hand for power grip as well as precision. So far we looked at the retinacular system on the dorsal side, and we see that there are quite a number of structures that are responsible for influencing the motion of the extensor tendon. So therefore, I call these extensors as the incredible extensors of the fingers. So because the reason I call these tendons as incredible is because extensor tendons depend heavily on these tendon supporting ligaments or the retinacular system to allow smooth and synergistic motion of the fingers and the thumb. So if we look at the strength variation between flexors and extensors, we can say that the extensors are somewhere between 4 to 6 times weaker than the flexors. There's no studies which has actually proven this, but we see that our hand is continuously working towards flexion in a resistive manner, depending on whatever activity you do, but seldom, the extensors are seldom resisted by in any action. And yet, in the normal hand, you can see that the normal hand does not develop flexion contraction. It's only the traumatized hand or patients having a disease process will result into producing flexion contractions of the finger. So how then the normal hand doesn't go on to forming flexion contraction is mainly because the retinacular structures mechanically is helping mechanical efficiency of the extensors, and therefore the extensors are capable of balancing their act against the forceful or powerful flexors. So we looked at the mechanism of extension. We can see that as we flex and extend our fingers, the lateral bands move volar as well as dorsal to the anatomical axis of rotation at the PIP joint. So we'll focus on how we move our fingers from a fully flexed position. So when the fingers are fully flexed, we can see that the lateral bands are volar to the axis of rotation at the PIP joint. You can imagine the spiral oblique retinacular ligament will be slack when the fingers are flexed. And because the lateral bands are volar to the axis of rotation, we can say that the transverse retinacular ligament being slack, the triangular ligament is maximally stretched, the oblique retinacular ligament is slack, and of course, all this orientation is in an abnormally either stretched or lax position. And then you can see that right over the curvature of the PIP joint, your extensor determ common, the central slip, which is connecting to the base of the middle phalanx, is sitting right over the curvature of the head of the proximal phalanx. We can say that when the finger is in flexed position, your central slip primarily is responsible for controlling all the mechanical structures allowing the fingers to move. So looking at the mechanism of finger flexion then, when fingers are fully flexed, the PIP joint extension is initiated by the central slip of extensor deuterum communis. And of course, as you activate your central slip, your lateral bands are equally tensed, and therefore they start producing some action at the distal interphalangeal level. So then, because of the activation of the central slip, then causing the loads on the lateral bands, we can say that the lateral bands then start to gradually extend the distal interphalangeal level. As we continue activation of the extensor deuterum communis, we can see that gradually over time, the extensors will glide more proximally over time. And with increased PIP and DIP joint extension, the extensor deuterum communis glides proximally. And with gliding or increased gliding of the extensor deuterum communis, the extensor deuterum communis is now influencing the sagittal bands and is pulling the sagittal bands proximally. And with proximal motion of the extensor deuterum communis and the sagittal bands jointly together will produce extension of the metacarpophalangeal. And once your fingers are extended and you hold the fingers in extended position, this extension of the PIP as well as DIP joint over the metacarpophalangeal joint is maintained by the action of extensor deuterum communis and intrinsic together. And if you look at the vector analysis, especially when the fingers are fully straight, the forces of extrinsic and intrinsic extension, the forces of the flexors jointly together causes the finger to remain extended because the forces are passing through the axis of rotation and the DIP or PIP, DIP and the metacarpophalangeal. So as the mechanism of extension is complex, we can say that the mechanism of finger flexion is complex as well. So when we activate, the finger is in a fully extended position. When we activate flexors to produce flexion, even though both flexor deuterum profundus and superficialis are acting together, the flexor deuterum superficialis initiates PIP joint motion first. And as a result, the spiral oblique retinacular ligament that you see here, it becomes slack. And when the spiral oblique retinacular ligaments become slack, the flexor deuterum profundus starts to initiate motion at the distal interphalangeal level. And as both these flexors are acting together, your extensors, even though they are working as an opposing force or they are acting as an antagonist to the flexors, they are now synergistically relaxing, allowing the lateral bands to move volar to the axis of rotation. So initially, they are dorsal to the axis of rotation, but with increased motion of the PIP and DIP joint, your lateral bands start to move volarly. And as that volar motion of the lateral bands increases, your extensor deuterum communis starts to move distally. And therefore, with the sagittal band motion distally, it is increasing the excursion of the intrinsics, giving you complete flexion of the proximal interphalangeal joint, distal interphalangeal joint, and finally, the metacarpophalangeal joint. And this is how we flex our fingers from a fully extended position to fully flexed position. Now you can very well analyze each and every structure, right from the extensor retinacular point of view, your juncture retinaculum, your sagittal band, your triangular ligament, your transverse retinacular ligament, and oblique retinacular ligament throughout the process of finger extension or flexion, giving you maximum amount of motion and load transmission. So looking at the mechanism of finger flexion, we know that when we look at the sequential motion of the fingers from a fully extended position, we can see that this mechanism is quite complex. On the volar side, we must have flexor deuterum profundus and superficialis having a differential tendon gliding in relation to each other in the fibroosseous sheath. The lateral bands must translate volarly as we perform the flexion, and transverse retinacular ligament and triangular ligaments should alter their tension in accordance with the motion of the flexors, pulling the fingers in flexion, and motion of the extensors, allowing the extensors to allow flexors to move. And this joint collaboration of flexors, extensor, and intrinsic, in collaboration with the retinacular system, will help in modifying the forces by the pulleys and allowing the fingers to move. So you can see that how beautiful that management is. But there are other structures which also play an important role in maintaining the joint stability, maintaining the mobility of each and every anatomical structure. And especially when the fingers are fully straight, your volar plate acts like a check rein mechanism. And then, of course, the check rein ligaments of the volar plate minimizes excessive amount of hyperextension at the PIP joint, because we need to have a mechanical equilibrium that is necessary for us to maintain motion of the finger. So here, of course, we have dissected out the volar plate. We can very well see that upon having dissection of the volar plate, the volar stability is lost, and therefore the dynamics of equilibrium is disrupted. So this is a complex mechanism, and all these structures should be retained during full extension. So when the fingers are in full extension, the forces of flexors, extensors, and intrinsics pass through the center of each and every sphere, creating a mechanical equilibrium. So you can see that if the forces are passing through, we can allow the structures to move smoothly and synergistically during flexion. And of course, we can allow the skeletal system to move in extension. And of course, this is a variable tensioning of anatomical structures that we need in order for our fingers to move sequentially. And in order for the structures to move sequentially in a smooth and synergistic manner, the retinacular structures produce a balancing act continuously throughout the process of motion between dorsal and volar tendons that are responsible for flexion and extension. Therefore, the mechanism of finger motion is so precise, depending on the amplitude of tendon motion distally, proximally, the translation of the tendons volarly as well as dorsally, and all this refining of the finger action or motion of each and every structure is done by the retinacular structures. So if we cut out some structures, we can see that if you cut out the retinacular structures, we'll often see there's a disturbance of tendon motion. There'll be a presence of ligamentous instability. And of course, the skeletal alignment will be completely disrupted, giving you either pseudo Boutner or swan neck deformity. And then based on that, you can see the changes occurring at the metacarpophalangeal joint as well as interphalangeal joint. You may see claw hand, swan neck, or Boutner deformity. So just one clinical example that sort of shows us how the retinacular structures work. So here, of course, there's a high energy impact. We know that upon rupturing the central slip, the lateral bands fall volar to the anatomical axis of rotation, especially at the PIP joint. And here, of course, you can see that the transverse retinacular ligament is retaining the lateral bands volar to the axis of rotation. And as a result of the lateral band being pulled in a polar direction, your triangular ligament will attenuate. And as that happens, as the person attempts extension of the metacarpophalangeal joint, you can see that the lateral bands form a noose around the proximal phalangeal head. On attempt of extension, the metacarpophalangeal joint rights in hyperextension, following the sagittal band, as well as your gensere tendon to have unstable exertion, and with pulling of the proximal phalanx in hyperextended position, your flexor determinum superficialis will pull the middle phalanx in flexion, causing more of a disturbance of the triangular ligament, and of course, causing or producing laxity of the spiral oblique retinacular ligament. And based on these anatomical changes that occur as a result of a trauma, if not treated, then Boutonniere deformity is divided into different stages. So stage 1, there is a minimal extension deficit. In stage 2, various changes have occurred as a result of adaptive shortening. And then gradually over time, changes are likely to happen, giving you increased sagittal band laxity, volar plate contracture, spiral oblique retinacular ligament contractures. And then, of course, these changes will then create even mechanical disturbances sequentially everywhere. So in this situation, of course, number of tests that you would perform will appear positive. And then, of course, that explains the pathomechanics of the deformity that we commonly see. And with this type of situation, if left untreated, the forces of the flexors are so magnified that it will eventually cause proximal subluxation of the middle phalanx over in relation to the proximal. So here is the middle phalanx. The subluxation of the middle phalanx in relation to the proximal phalanx causing significant amount of disturbance. So with the pathomechanics, you can very well imagine that if injuries like this are left untreated, various anatomical or retinacular structures will change over time. And of course, these will produce number of changes, giving us the deformities, which will become difficult for the therapist or surgeons to manage. So this is another example. The person has Boutonniere deformity, which was treated by means of specific order in order for us to identify what is happening, why he cannot extend the PIP joint. We can see that by placing the distal interphalangeal joint in flexion, we identified that the triangular ligament had attenuated, and by placing the DIP joint in slight flexion, the person has an ability to extend the PIP joint beautifully over time. So therefore, we can use some specific techniques to influence the retinacular structures in order for us to regain mobility of various joints. So why am I using the DIP spline inflection? Is by, especially you can see that the lateral bands have fallen over to the joint axis here. By flexing the DIP joint, you're relocating the lateral bands above the axis of rotation. And you can see that the changes are made as a result of modifying these vectors, as you can see, by just small little splinting. So here, of course, the person has extensor atrium communis adhesion following a repair. He shows the moment he starts to extend the finger, the metacarpophalangeal joint writes in hyperextension. Here you can see that patient still lacks extension of the proximal interphalangeal level. So that is treated by means of a relative motion splinting, keeping the metacarpophalangeal joints in flex position. And of course, you can over time, unfortunately, this video is not moving, but anyway, so over time, the patient will regain proximal extension of the central slip and giving you full extension of the finger. So in conclusion, we can see that the retinacular system has significant influence on normal finger mechanics. Any result causing an injury to these structures will produce displacement of some anatomical structures, producing various deformities. And therefore, it is very important for us to have a thorough understanding of the normal finger motion as well as abnormalities that we commonly see following an injury. However, we must consider the influence of the retinacular system and as to how we sort of create a balancing act between various structures in order to restore normal functioning of the finger. Thank you. Any questions?
Yes, any questions, please? Or you may write in the chat box. Yes, Dr. Shrikant,
Yes.
Shilpa has written, how would the splinting change with respect to stage of Butner deformity?
Okay, so initially, let me close this program just 1 second. So initially, if a person has an injury, I don't know why. Just 1 second. Give me just 1 second if you don't mind, please. Okay, so it's a great question. So if a person has acute injury to the central slip, we can see that the lateral bands will start going into volar direction. So as a result, you'll see that the transverse retinacular ligament is pulling the lateral bands volar to the axis of rotation. And of course, because the lateral bands are still intact, they're producing excessive tension on the distal phalanx, causing the distal phalanx to ride in hyperextension. So when these patients show this kind of a zigzag deformity, if you look at the metacarpophalangeal joint, it will always show a tendency to ride in hyperextension. So in order for the person to have complete anatomical anastomosis at the avulsion side, we need to bring the MCP joint in about 30 degrees of flexion. Because studies have shown that by placing the MCP joint in 30 degrees of flexion, you're creating relative tension on your extensor apparatus. That's one. And then bring the PIP joint in neutral and leave the DIP joint free for motion. Because we know that upon disruption of the central slip, the lateral bands are volar to the joint axis, your oblique retinacular ligament are slack. And of course, therefore, you want to maintain the MCP flexion PIP joint in neutral and allow the person to flex the DIP joint. By flexing the DIP joint, you are maintaining the anatomical length of spiral oblique retinacular ligament, one. You are retaining the lateral bands above the axis of rotation at the PIP joint, and you are minimizing any excessive amount of displacement load at the site of rupture where the tendon has avulsed from. So that means that the tendon is sitting very close to the site of its insertion, and eventually that tendon will heal. And then with the healing of this, the finger will have an ability to initiate motion of the PIP joint first, as we see the normal mechanism of digital extension. So that's in stage 1. But in stage 2, you obviously have to assess the patient's structural changes. So if the lateral bands have remained volar to the joint axis, you can see that patients are likely of having limitation in terms of flexing the DIP joint when the PIP joint is held in extension. So if you have this in stage 2, you're going to maintain the PIP joint in flex position. You may have to use some dynamic stress to the distal phalanx to relocate the lateral bands dorsal to the joint axis. And then depending on the amount of limitation that you identify with your clinical examination, you may have to consider using serial static or serial casting technique if the patients have dense contracture of the PIP joint and volar plate. And then you gradually bring the PIP joint over time in neutral. And then, of course, you allow the DIP joint to flex, because ultimately you want to relocate the lateral bands above the joint axis and regain anatomical length of your spiral oblique retinacular ligament. So that's the answer of treatment of various stages. But if a person is in grade 4 or stage 4, Of course, if the patient does not respond to splinting or serial casting for that matter, then they become the surgical candidate. And in surgery, they can do various procedures by doing a plication of the triangular ligament, realigning the realigning the lateral bands above the joint axis. And then, of course, you may have to consider, connecting, spiral oblique retinacular or releasing spiral oblique retinacular ligament, or you may have to do dissection of the volar plate release. And then there are various procedures described for chronic Boutonniere deformity if the patients have not responded to the traditional conservative management. I hope I'm answering your question.
Yes, sir. Sir, one thing I wanted to just confirm is that irrespective of that, the MP should be flexed, right? The MP should be incorporated.
Definitely, because if the person has a PIP joint flexion contracture or an extensor lag, you will see that patients will often have hyperextension tendency at the metacarpophalangeal joint. And if the MCP joint continuously hyperextends, your sagittal band will continuously be loaded towards extension. And as a result, you will not be able to restore the balance between the MP joint, PIP joint, and DIP. So therefore, long-term usage of your relative motion splinting or MP block splinting is necessary, despite of these patients having whether conservative management or surgical management.